And it has just grown and grown and grown over the years. And we're just really excited about that, and really glad that it has become such a part of the fabric of UT and all the work that they're doing around social determinants. Such a good connecting point for health, for Methodist healthcare, and for a lot of the organizations in our community that are doing some of the work that we're going to be talking about in the course. So we're glad you're here. Hope that it's a good experience for you. Think that it will be, and we're eager to get started. So as I said, my name is Jonathan Lewis. I wear a number of hats. I work full-time at Methodist Healthcare. I'm the Director of Community Partnerships there. Do a lot of our sort of externally facing partnership work, especially with churches and with schools. My background is as a hospital chaplain. That's how I got my start with Methodist Healthcare in 2008. And you'll hear a lot more about that and about me next week. Because I'm the presenter next week, so you'll hear probably more from me than you need to. So that's all I'll say about me right now, except again that I am probably pretty much your main connecting point for the course. Again, if you've got to miss a class and you're going to submit a reflection essay to make up for the absence, that comes to me. If you have a question about your very short service assignment, if you have your syllabus, thinking about how to do that or what it should be or any other requirements that aren't there, let me know. Things about schedule, maybe even opportunities for connecting after the course is over. All of these things that feel free to reach out to me. I probably can help you, and if I can't, I will make sure that I find the person who can. But everybody has the syllabus for sure in your email. If not, I brought some extra copies, and they're on that purple table in the back. So grab one if you need it. Especially if I know we had late additions to the course. And if by chance I didn't email you the syllabus, feel free to let me know. I can send it to you. Also, we have it in the back. So I don't know if there's anything in here probably that we need to spend time on tonight. Except maybe, again, just to emphasize the attendance, we really want y'all to be here, to be present with us and our speakers, to be present with each other and what you're learning. And so that's why we require that as part of the attainment of the certificate for this course. We know that life happens, school happens, y'all are very busy people, so certainly if you have to miss a session, you can make it up with the reflection piece. That's okay, but we do require that you be here for at least 3 in order to get it. I will pass around an attendance sheet right now. So y'all do find your name there. If it's not there, then write it in somewhere, but I think it should be. Those were the names that I had as who was enrolled for the course. So just sign next to your name, and like I said, if you don't find it there, write it in, and then I may follow up with you later. Any questions for me about sort of course logistics or contacts or what to expect, anything like that? Well, we're going to do a lot of what we said we were going to do tonight. One thing that we're not going to do, that we said we're going to do tonight, is to hear from Dr. Scott Morris in person. That's him right there, and we got him all queued up and ready to go. Dr. Morris going to be here tonight. He is presenting, I think, at an awards banquet, and really missed being here. He is always here for the first line of this class. He loves this class. He loves the UT connection, and I assure you, he would have been here if there were any way that he could have. That said, he made a video for you all, which we're going to show in a minute, and you're going to get to hear from him and some of the story of church health and what this place is and how it came to be. Anything that you hear about tonight or in the coming weeks that you want to know more about connecting to church health, anybody you want to make a connection with Dr. Morris, I'm sure he would love for us to help you make that happen. So he couldn't be here tonight, but we do have a video from him, so we will start by hearing that.
Hi, I'm Dr. Scott Morris. I'm the founder and CEO of Church Health, and I can't believe that I'm not here tonight in person for the Serving the Underserved course. It's something that I care deeply about, as does all of Church Health. But I'm glad to have this opportunity to talk a little bit about why we do it, and really about the work and mission of Church Health and how we are hoping to inspire all of you who are out there to want to do similar work at some point. So let me just begin by telling my own story and how I got involved. So I actually grew up in Atlanta, and growing up in Atlanta was always interested in the church, and the idea of being professionally involved and caring about my faith mattered deeply to me. But the thought of preaching 52 sermons a year sent shivers down my spine, still does. I have no idea how anybody could do that. But as a teenager, I read the Bible and came to realize that a third of the Bible has to do with healing the sick. It's literally on every page. But I would look around to see what my church or what other faith traditions did, and I just wasn't very impressed. There wasn't much to it. We prayed for people, we visited people in the hospital. You know, all over the country, we had built large hospitals that have church names on them. They do good work, but they literally had almost nothing to do with worshiping congregations. It seemed to me that there ought to be more to it than that. So I go to college, I go to seminary. I spent most of my time in seminary looking at what the church has historically done and came to realize there's a reason these hospitals have church names on them. We just forgot. I'm not going to give you a long song and dance history lesson, but if we look just at this country, you know, prior to the Civil War, if you were sick, the most likely person anybody would have seen for healthcare in America was actually a pastor. You know, pastors provided virtually all the healthcare in this country. Just one person to tell you about is John Wesley, who's the founder of the Methodist Church. Wesley actually thought every Methodist society, indeed every church, should be involved in direct hands-on healthcare. Wesley actually wrote a book called Primitive Physics, which was so successful in the American frontier that as late as 1850, if we were in Memphis in 1850, there would have been a greater chance that you would have had a copy of Wesley's book, Primitive Physics, than you would your own copy of the Bible. Now, I fully confess Wesley had some unusual ideas. He had at least 18 different cures for baldness, most of which I've tried myself that didn't really work. But really more to the point, Wesley believed that every Methodist society and every church should, again, be involved in direct hands-on healthcare. For Wesley, it mostly had to do with the coal miners of Western England. But when he came to America, even though he was not a very successful evangelist, his ideas around healthcare actually caught on. Until as late as 1863, a pastor in Guilford, Connecticut, wrote the standard textbook of physiology. Now, things are clearly not that way today, right? That things have changed. Part of what we need to understand is, you know, how did we get to have these hospitals that have church names on them? Well, around the turn of the 20th century, there was something called the social gospel movement, started by a guy named Walter Rauschenbusch, who believed, along with so many other people, that all the new science that had come about in the late 19th century around medicine and healthcare should be available for everybody, including the poor. And as a result, Rauschenbusch and others used the resources of the church and the broader faith community to build hospitals all over America whose primary purpose was so that the underserved, poor people would have access to all the new knowledge. So this is why these hospitals are named Baptist or Methodist or Saint whatever. It's because the intention is that we were going to provide health care as best as possible for the poor. Now, things changed for a lot of different complicated reasons. One becomes the fact that medicine becomes a business, becomes very complicated, becomes very expensive. And yet the reality is that so many people are working and yet uninsured. So I end up going to medical school after seminary. I then do a residency to be a family doctor. Along the way, I, in the Yale Medical School, encountered a little pamphlet called How to Start a Church-Based Health Clinic. And I go, that's it, that's what I want to do. And then I'm finally ready to start my own church-based health clinic. I wanted to stay in the South. I didn't want to go back to Atlanta. And then, not making this up, I read somewhere that Memphis was the poorest major city in America. And based on that, I said I was going to Memphis. You know, at that point, I was 33 years old. I was too young, too dumb to realize that what I wanted to do had no chance to succeed. You know, so one of the reasons I tell you that part of the story is that, you know, I believe that some of you may have your equally crazy ideas about how you want to go make a difference. And yet people are going to tell you right and left that it'll never happen. It can't possibly work. It's too ambitious. You know, just look at the story of Church Health and go, you know, they were able to do it. Maybe I can too. Now, our focus when we opened in 1987 was to provide care for the people who work to make our lives comfortable. Things have not changed over the last 35 years. So we take care of the people who cut our grass, wash our dishes, take care of our children, will one day dig our graves. They don't complain. Yet when they get sick, their options are very few. In 1987, there were 26 million uninsured Americans. That number grew to over 50 million. And today, even with the Affordable Care Act, that number is almost 27 million, more than there were when Church Health began in 1987, plus the immigrants. You know, nobody counts the immigrants. You know, if you are working and you've been in Memphis for 20 years building a house and you fall off the roof and break your leg, what are you supposed to do? You know, even back when Bernie Sanders advocated Medicare for all, Medicare for all didn't actually mean Medicare for all. It only meant people if you were native born and you at least had a green card. Otherwise, the plan would be to go back to Mexico. Well, I don't think that is how it should be. You know, if somebody in that situation comes to me and God puts them in front of us, I want to say we did the best we could possibly do. That is what how Church Health has really focused all these years. Now, when you think about the underserved, it's not just about giving them pills. You know, one thing we need to be crystal clear about is that all pills are poisons. That's how they work. You know, they poison your body from doing something it is naturally trying to do. You know, you got to be pretty doggone smart to override the body the way God created it. You know, thank God the pills don't always do what they tell us they would do on TV. If that were the case, we'd be killing people right and left, which is unfortunately all too true. You know, so how Church Health thinks about it, and how I hope you'll think about it too, is that you know, being healthy is not about the absence of disease. You know, the World Health Organization will agree with that. You know, who cares if you live 2 years longer if it means 2 years longer in a nursing home? Life for life's sake can't possibly be the point. Breathing in, breathing out, none of us are signing up for that. So what we think being healthy is about is ultimately three things: having more joy in your life, having more love in your life, and being driven closer to those things greater than we are. Now, we would call that God. You don't have to call that God. But for all of us, there are things greater than we are we need to be drawn closer to. Now, if this is what it takes to be healthy, more joy, more love, and being driven closer to God, it doesn't have a lot to do with the doctor, which is what led us to create what we call the model for healthy living. You know, this is just a riff on the social determinants, but we think there are 7 things in life that are equally important in order for us to be healthy. So one is medical care, but it's only one. You know, I think all of y'all know by now that only 10% of anybody's health outcomes has anything to do with the doctor, the hospital, or drugs. 10%, that's it. That our country is spending $1 trillion a year on those 3 things. I think you should argue that we're not spending the money very wisely. There are other things that are equally important that matter in order for us to be healthy. Now, the next is nutrition. Your mother told you are what you eat. She was right. Movement. Our bodies were made to move. Emotions, family and friends, work. We define work as those things that bring meaning to your life. And lastly, your faith life. Your faith life is as important as anything the doctor would do if you're going to be healthy. Now, we're not advocating you evangelizing patients, or nobody wants to have the doctor or nurse or physical therapist or dentist impose their belief system on them. But it's been shown over and over again that patients do want to be able to talk to their healthcare provider about their own faith issues, and the issues of spirituality matter for that person to be healthy. So we hope you will learn how to do that as time goes on. It's something Church Health cares deeply about. So this idea drives all of the work of Church Health. It is also part of how we can think about serving the underserved as being more than just finding a way to pay for technology and pay for drugs. Unfortunately, in our healthcare system, we have developed an unholy love affair with technology. We've come to believe that people can live any way they want to, and it doesn't matter, because when they're broken, the doctor could use that technology to fix them. Well, I hope you have learned so far in your training that the technology is not that good and the doctor is not that smart. God gave us this body for a reason, and we have an obligation to take care of it. So I think this is a very important part of what serving the underserved is all about. We need to help people understand the reality of what it means to live a healthy life. Nutrition being an important part of that. Yet, one of the things we are challenged with is the philosophical concepts of Plato and Descartes. Both Plato and Descartes, 17th century French philosopher, convinced us that we can take a human being and separate us into a body and a spirit. And we have put the body on one side and said it's the purview of science and medicine. We put the spirit on the other, said it's okay for the church and people of faith to mess around with our spirits, but heaven forbid we cross that line and care about our bodies. But this idea known as Cartesian dualism is fundamentally flawed. It is a non-Christian, non-Jewish, non-Muslim, non-Hindu idea. Every world religion completely rejects this idea that the reality is that we are dust and breath. We are body and spirit. And we must care for our bodies as well as our spirits if we're going to be whole. In your training, never forget that there is a spiritual dimension to life. And look, all of your testing is going to be built around, do you know that the knee bone is connected to the thigh bone? And can you pick that out on a multiple choice test? But the reality is that human life is much more complicated than that. And that is especially true among the poor. One of the great things in my life has been my ability to be engaged with people who truly have nothing, who have taught me a great deal about the important things in life. Over the years, I have seen many, many people who are older, who may have grown up even picking cotton, who've lived a very difficult life from their work standpoint physically. Economically, they have very little. And yet when I will walk into their room and ask them, how are you doing? The answer I invariably get will be, I am fine and blessed. Really, you're fine and blessed. You have nothing. How can you be fine and blessed? Because economically, in a way America views it is you have no capital. Well, what they do have is an abundance of spiritual capital. And what I've been able to learn from them over, and I hope you will do as well, is what does it mean to have that kind of spiritual wealth? And I get a chance to spend the first few minutes of my visit with them, making sure that medically I'm not messing up. And then I get to, with the last few minutes, be able to ask the question, how do I get to be fine and blessed? What do you know about life that I need to know? I think that is one of the most important experiences I have had over the last 35 years at Church Health. And I hope you will start now to develop a way to engage patients in a similar way. Now, serving the underserved is very difficult, and it can lead to burnout in a lot of different ways. I also believe that the nature of our healthcare system will push you in a way that is counterproductive to caring for people who are fine and blessed. You know, our system is broken in so many ways, partly because of our mechanistic understanding of what we are about to do. So I tell a story every year, but I want to tell it one more time, which is when I was a third-year medical student at Emory in Atlanta, I was part of a team that was called in to do CPR on somebody who had arrested. It was an older man. He was very poor. But I was doing the chest compressions, which was the role of the third-year student at the time. And the team was doing everything we were supposed to be doing. And then the senior resident came in and asked the question, hey guys, when this is all over, where are we going for pizza? And I found myself thinking that I want pepperoni. At that point, I was about to go over into the abyss. And I pulled myself back because I came to remember and realize that this was a real human being whose life was underneath my hands. I'm begging you not to be converted to what I call the religion of medicine, which is what this is all about. It's also really important, if you want to serve the underserved, to find a way to be connected to your patients in ways that are not just about their disease, their diagnosis, and the test that they just recently had. Also, as a medical student, we were on rounds, and another medical student with me was making a presentation and began her presentation talking in great detail about the patient's life. All very important, I believe. Only at one point, the attending called her out and said, young lady, I think you have gotten too close to your patient. Look, the reality is you cannot get too close to patients. There is a way that we all have to find a way to be engaged in people as human beings. The fact of the matter is, it is natural for us to keep a distance from another human being. But we don't have to be taught how to do that. But what you have to learn how to do is how to draw close to somebody else. That actually does not come naturally. Yet medicine tends to push us in the opposite direction. You know, the more you're engaged with your patient, and especially people who are underserved or who are poor, the greater it will be in your own life, but it will also help you create a dynamic that provides better ability for you to actually care for people. Now, there's so many other issues here that we're going to talk about through serving the underserved. Just realize the economics of this are brutal. The Affordable Care Act was intended in order to expand Medicaid so that poor people would have access to an ability to pay for their healthcare systems. But unfortunately, the Supreme Court allowed for the state of Tennessee and Mississippi to not expand Medicaid, so it's not available to our patients. You might say, well, they can go to the exchange, but the exchange only allows people whose income are above 138% of the poverty level. not below, above. So that means of the 80,000 people who Church Health takes care of, more than 90% of them, if they go to healthcare.gov, they are told that they don't qualify. It is not possible for them to get any type of subsidy to buy health insurance in the open market. You know, what that means is that the poorest people get nothing, nothing. You know, Jesus said the poor will always be with you. So far, he's been right. I just don't think he ever thought there were going to be so many poor people. So look, this is going to be a transformative experience with you in this class if you let it. I hope you will get engaged in this type of work. Church Health will be here for you. You're going to meet a lot of folks over these 4 weeks that are doing the work. There's many different paths to be able to caring for the uninsured. You need to find your way. And Church Health will be here for you if you want to be inspired. I hope some of you will ultimately decide that after you finish your training, you want to come back and work with us. It's a great place to work, and we wish you only the best.
I'm Dr. Susan Nelson, I'm the medical director of Church Health, and thank you for coming. I'll start out with a little stilted. So we our AU support people who told me that they can send out a link later if you want to watch it and get, you know, it's just the audio is sort of. Anyway, I do want to apologize again on behalf of Dr. Morris. He wrote the ratings course and he can't quite be on it. So he's different. Things and so there was a few points that he made that I want to re-emphasize. And one is that I'm a family doctor, I've been a family doctor for 30 something years, and I worked here for 7 years. I was a volunteer here for probably 15 years before that. And the reason I love working at Church Health is that, you know, he talked about treating patients as human beings, and we all want to do that. But I think you all are here because you realize that the system doesn't necessarily train you. You really have to, push back, you know, because there's so much knowledge that you have to learn and pass the test and then around it never in time. And yet you have a real human being in the bed that is suffering, and maybe it's a little, you know, just need to sit with them and hold their hand. So Church Health tries to at least acknowledge that we are all spiritual beings, we're not just the gallbladder and 400, you know. So it's a great place to do that. And then the inequities, and we all recognize there's inequities in our society, but the inequity in the healthcare system is just incredible, right? I mean, if you, and you know that, I don't know if you talked about this, I don't think so, but the current health insurance system in America is based on the employer. You know, after World War II, everybody came back, got a job, and the employers wanted to recruit people, so they said, oh, we'll also offer health insurance. So if you don't have a job with a company that can afford to pay for health insurance, then, you know, you're out of luck. And so the folks we take care of here, they work really hard. You know, they work for maybe $15 an hour, and cleaning house and, you know, serving food, and musicians. We have a delightful practice here because I have lots of folks that are musicians, people that own their own business. We have a lot of immigrants, people from Syria who were engineers where they were, and now they're bringing a gas station. So just fascinating. So, so I want to emphasize that. And then to say that I'm going to introduce a couple of people. Meredith Walsh, maybe stand up or raise your hand. So Meredith is a family nurse practitioner, and she's helping me. She works here at Church Health. We're very grateful for her. She has a very interesting history, which she's going to talk about maybe in 2 weeks, maybe in 3 weeks. One of the last night, yeah. Yeah, she has worked in refugee camps and lots of interesting places. So And then I want to introduce Melissa Barnhart, who is a baby doctor, right? Just graduated from residency. Huh? Yeah.
My favorite thing about like teaching.
She's also been at Pete's, but I meant compared to me, the old one, you know, she's just got that residency. So I said, if you want to just come in here if you would, I was hoping that you would just tell a little bit about, she just finished her residency. And one thing about primary care is that salaries have just finally gone way up. Well, but she didn't take one of those big fancy jobs about. She came to work at Truth Health, so maybe she can talk a little bit about why did she do such a thing?
Yeah, hey y'all, thanks for being here tonight. I'm gonna stand in front of this so I'm not looking into that light. So again, my name is Missy Barnhart. I just finished residency in 2021 and then did an internal medicine chief year for a year. For those of you that don't know, sorry, it's just an admin. And a lot of people use it to figure out if they want to do something else beyond that in fellowship, yada, yada. I'm kind of unusual, and then I did not student academics, and I did not do a fellowship afterwards. Much like y'all, I didn't actually get the chance to take this class. I just had my son in medical school when this class was being offered, and I just did not have the time in my schedule, but it was something that I really wanted to do because I always wanted to work with underserved populations. You know, Dr. Morris talked about it some, but like central to who I am is my faith. I'm a Christian, and the way that I live that out is in my everyday life. And so I consider my job to be not just a job, but a vocation and a calling. And so I want to do that to the best of my ability. And part of where I see myself working in that is working with people that don't have all of the resources that the rest of us have. If I need to go to a doctor, I can go over to Wolf River and there's 40 of them that'll fight to take my insurance and see me. And that's not the patient population I wanted to work with. I wanted to work with people that don't have enough doctors to serve them. And if you look, you can find information on on the disparity of number of doctors to patient ratios as it in Memphis, in the zip codes that are inside the 240 loop versus out in Carterville and Germantown and Bartlett and Cordova, and it is dramatic, as is the life expectancy discrepancy. And I know they're doing a better job of teaching all this early on in medical school sometimes. And I know I'm not all of y'all are medicine, but it wasn't something that I learned a ton about until I got to residency. And so when I was looking for a job, I really had to kind of seek out the places where people who are underserved go, because a lot of times those locations don't have the resources to go out and recruit. And I mean, what's your recruitment tool? Like, hey, come work for us. We'll make half of what you work if you go be a hospitalist or Baptist. We can give you really meaningful work. And for a lot of people, that's not enough. But for me, it was what I wanted to do. And so as I looked around and as I worked, actually worked in Regional One's clinic all last year, working with the residents, which is another place with a hugely underserved patient population. Nowhere had the resources that Church Health does. I cannot begin to tell you how amazing it is being here. You know, we always say for anxiety, depression, I always counsel my patients, like the medicines do 20% of the work, but you have to do 80% of the work with counseling. I can help you, but counseling is where you need to begin. I'm not trying to be a counselor. I need help with that. And I don't know if any of you all with insurance have had to try to find a counselor. It's hard. It's hard even when you have insurance. And so for people without that, I mean, I know all last year, I would give people handouts and resources to go to counselors, and the most motivated of them would come back and say, I tried and I called and I tried and I can't afford it, or they don't have appointments. And today, my last two patients of the day, both the PHQ-9 is a screener for depression. The max score, I think, is 27. and I had a patient score 22 and one score 27. These are, or, sorry, 22 and 24 on that screener questionnaire. There was my last two patients of the day, and I was able to have a counselor meet with both of them before they left their appointment, and then get them plugged in with our counseling team here at Churchill. And that sort of resource is not available anywhere. Yesterday, I had two patients back to back, both young women under the age of 40, had come in for UTIs and actually had yeast infections. They were both new onset diabetics with hemoglobin A1Cs over 10, so very poorly, poorly controlled. And they both needed medicines and insulin and teaching and glucometers and a lot of support. And I get 15 minutes per patient visit, and I'm still big at it, but I'll spend only 15 minutes. I'm not quite that efficient yet. But I spent time with them and then was able to connect them to health coaches who could come and talk to them before they left and make sure that they can, we have an arrangement from pharmacy who can help, who sets their prices at a certain level so that our patients can absolutely afford certain medications that are life-saving. Can I get them every vaccine medication? No. Sometimes I can, if they're established, but even somebody that walks in off the street that needs that kind of care, I can give it to them. So I don't know that I totally answered the question, but this is the kind of work I want to be doing. I want to be providing really quality healthcare with all the things that we do recommend with all of our large accrediting bodies, American Diabetes Association, the American College of Cardiology, all of that stuff. And I can do that here because I have all of the wraparound services available to me. And so that was more meaningful to me than earning double my salary working as a hospitalist for half a year at a Baptist. And if you want to know more about that or have questions about that, I'm happy to talk about it. And I'm picking on Baptist, it's anywhere. But yeah, this work is really meaningful. The patients are amazing. I have a lady that told me she'd bring me fun later this week, and I'm super excited about that. So, I have a wonderful patient population. I love what I do. And I'll let Dr. Nelson give y'all my questions. Yeah, if you have questions, I'm happy to ask them. And then I'll also make sure that y'all have access to my email. Because I would love to answer any questions.
Very, very well. So I just wanted to say, I wanted to ask, so medical students, raise your hand. Okay, nursing, dental, no dental this time. Therapy, occupational and physical. Okay, pharmacy, we usually have a good group of pharmacists. No, what am I leaving out?
Graduate health.
Graduate health, tell me what that means.
The pharmacology program.
Okay, yay, yeah, Alex Jen. See you next class.
To tell you hi.
Yes, of course. So he was a scholar, so we have a program, 1-year program, usually 1 year, for people who graduated from college and are trying to get into some kind of professional school generally, or they're just exploring not only what they want to do, they spend a year with us, and so Alex spent a year with us. Yeah, so please tell the club. My husband, David Nelson, teaches y'all too, that's the connection, yeah, so. All right, so, yes, I would love to open for questions, and just also, the last thing I do want to say also that we do have, so we have a dental clinic, we'll do a tour in a little while, that we're going to split up, and y'all can see our dental clinic. The dentist here. Behavioral health, the behavioral health is the most beautiful space in the clinic. They've got all windows, and it's amazing over there. And we have, dental eye, we have optometry clinic, which is amazing. So we have one of those those retinal cameras, that you take a fundal picture, and so theoretically, our diabetics, when they come, will get that done. That Sam sometimes has time to do that, sometimes not, but yeah. So a lot of services.
One other thing I wanted to say, so working, right? You look, it's iron, yada. if you want to offset some of the costs of your debt as you work with underserved patient populations, I know y'all have heard about the, loan repayment program from the federal government, but the state of Tennessee also has a stipend program, and this, I know it's for medical students going into, or, no, it's for residents going into practice, but I think it's available to some of the other allied health professions, but it's called the Tennessee Initiative for Workforce Development, and anyways, they will give you a stipend, of like $35,000 a year for each year of residency that you do. But it's only for primary care residencies, and you have to agree to work each year of residency in an underserved area. So like I did a 4-year med-peds residency, and so I anticipate being here much longer than that, but like at the very minimum, I have to work 4 years in an underserved primary care setting in the state of Tennessee. So if that's of interest to any of y'all, you can ask me more about that too. You can also just Google it. That's one of there are incentives, and there are more, but there are incentives to working with underserved populations.
Well, I would say, I don't think we quite, we want to have. Yes, we have to stick up for us a little bit. We're a little better. We're kind of in the 75% range. It's not quite so bad, but anyway. Questions about? No? Y'all are tired. I know it's kind of hard at the end of the day. One other thing Dr. Morris pointed out that's really important is that for me, the way I keep, so when you go through training, nursing, pharmacy, medical, you can come out kind of bitter and resentful on the other side, right? Just, right? I mean, right? Yeah. So the way to not do that is to connect with patients. Right? I see somebody not of an interview. I mean, when you're at the VA, and everybody has problems with the VA system, and it's just very personal, but you connect with a patient and listen to their story, which Jonathan's going to talk about that next week. When I clue into who the person is, not just their diagnosis, that just makes all the difference. And that's how Dr. Morris says, how you get to be fine and blessed. You connect with the human being on the other side of that description. So, and I'll just encourage y'all to remember that, despite the fact the whole system says you don't have time to do that, you really do. And you can't do it with every single patient, but if you can do it with at least one patient a day, you remember that you're a human being and they're a human being. It's the American honor effective. That's going to keep you from being bitter and angry. Is that you're done with your training?
And I really will, y'all interrupt me if you do have questions, just raise your hand, I'm not scary. But one patient story that stands out to me from my time here, I had a young Black man come into my exam room. He was with his mom and his sister in a wheelchair, and he was there for left-sided pain. What is left-sided pain? I don't know how to fix that. So I go in the room and we start talking. He's just been discharged from the military. I don't know what the circumstances were surrounding that. But he didn't qualify for VA. He had been to, I think, 3 ERs for this pain down the left side of his body. And each time he'd been given an x-ray, given some naproxen, and told to, essentially that he was malingering. But he didn't need to come back, that he needed to go see somebody else. And so he comes into my office, and my medical school neurology physical exam, y'all pay attention in that class, helped me figure out that he had a C4 disc compression, and he had cross-body symptoms. He was weak with diminished reflexes on the left and had altered sensation on the right, all the way up to his collarbone. And of course, he's not an established patient with us. So I call our referrals department. I'm like, please, can I get him an MRI? I'm like, right now. And they need to happen. And sure enough, he's got disc compression, but he has spinal as well. And what had happened is over the previous 2 months, he had gone from being fully active, deployed in the military, able to do everything, to slowly over time not even be able to walk. And we got him into the ER. We got him neurosurgery 3 days later. And a week after that, he followed up with me in the clinic, walking with a walker and doing fine. And he's gonna make a full recovery. And like, number one, if you told me I was gonna get to diagnose spinal cord edema in my primary care clinic before I started this job, I would have thought you were crazy. But when you don't have resources and your ER is your primary care, and finally you get in to see somebody that's not trying to decide, are you gonna live or die on me right this moment? You know, you get to take care of some really advanced pathology, and number one, that just like tickles the brain, because I love an interesting problem to solve, and it's part of why I love medicine so much. But two, you get to be a compassionate voice in these people's lives who oftentimes have not had or been met with a lot of compassion within the healthcare system. And it's a really great privilege.
How possible do you think it is to like serve the underserved population outside of primary care?
Hugely. Which one are you considering?
Um,
Okay, so one of the things that helps us so much here at Church Health is our volunteer specialists. So actually use our derm consult a whole lot. But we have, you know, we have ortho, we need neuro, we need more rheumatologists, we have endocrine, we have we have ENTs. I know there's an ophthalmologist that works in the eye clinic. There's a huge need for that. There's,
That's the secret sauce. So we have volunteers that come on site, and then we have volunteers who see people in their clinics. So like Sutherland Cardiology will see our patients, because I can't do a heart cath. She can't do a heart cath. So we have dozens of volunteers that do that. And in fact, so what's kind of cool is, Alex Jen was a scholar here. We have a couple of scholars, for example, Northley Thompson, he's a hand surgeon. So he was a scholar here, however long ago that was, right? Went to school, medical school, did residency, did the fellowship, and now becomes volunteers, because that's the longer period, right? That's the 10-year plan. Todd Chappell's a volunteer GYN. He was a scholar here some time ago. So Dr. Morris, in his wisdom, has built a system that I guess people want to come be part of, and then once you come, you kind of get bit by the bug and you want to stay part of it. But that people all are not going to come work at Church Health. I mean, a couple of you, but I think a bigger message is, as Dr. Morris said, you can do this. People will tell you you can do this. And you don't have to work full-time at a not-for-profit clinic. So I mentioned that I was volunteering here for almost 15 years before actually coming here and getting paid. So what that meant was Church Health would send me patients to see in my office, and I would see them for $5. And Church Health had worked out that the labs would be donated, the CT scan would be donated, they have to go to the hospital, that's all, like this young man that had his surgery, that's all donated. So wherever you're gonna be, whatever community, you can find some clinic that sees people for free or reduced cost, and you can volunteer your time. I mean, they would love to have you, trust me. So part of the course is to plant that idea in your head, and then part of the course is just to, we're gonna talk about, so what are some of those barriers? Because it's hard. You get kind of frustrated when people just really just not take any of these medicines. I mean, rich people do that too, right? Maybe they have less than a good big excuse, right? But, there's challenges, and there's days when your compassion is done. I got no compassion left. So fortunately, for most of our patients, it's a continuity thing. They come back. If I don't quite get it right the first time, they'll come back the next time. This is my secret in family practice, right?
and there's primary care, like I'm a primary care doctor, and and Dr. Nelson is family medicine, I'm internal medicine and pediatrics. And all three of those are primary care specialties. I mean, things like doing general OBGYN, general surgery, those like, because there's so much of specialty that you can do beyond that, if you stay just within that general, but at least I know the state of Tennessee considers you primary care, but you can do a lot of really great stuff with that as well.
No more questions, I think we will, oh, go ahead.
First of all, thank you for your real life stories. I don't know whether my question is in the field. So a person without any health insurance, irrespective of is a resident or non-resident, when he or she doesn't have any health insurance. So what is the best way for that person to seek out for maybe primary health care or any sort of health facility?
Also in Memphis, you come to Church Health because we have a walk-in clinic that we will see you if you don't have insurance and you're sick or hurt today. It's the best deal in town. For $40, you come, you see the doctor, you get your labs, your X, everything that we can do in-house is yours. Okay, it's a pretty cool deal. Now, Missy earlier was referring to being established. So Dr. Morris figured out pretty soon that he could not offer all things to all people, get people coming from Jackson, Mississippi to come up here, right? So he established that he designed the rules that to be an established patient, which means you have access to our network of all the donated services, the behavioral health, the dental, you have to live in Shelby County. Initially, it was you have to be uninsured, although we modified that a little bit, and you have to work 20 hours a week or be a primary caregiver for a child or an elderly person. So the reason we modified a little bit is we have a residency now in family medicine, and residents have to see Medicare patients because they're 65 and older, and they have to see kids who generally aren't taken care of. So we take the insurances that nobody wants to take, right? Because, if you, even with the Affordable Health Care Act or Affordable Care Act, people have access to insurance, but it's crap insurance, right? I mean, they can go to the hospital and mostly get their bill covered, but if you want something else, all those things. So, not to go on and on, but yeah, in Memphis, Tennessee, what you do is you have to choose yourself. But we have what's called Echo Clinics. So there's something called Trinity Clinic in Olive Branch that opened maybe 2 years ago, and they're basically modeled after Church Health. We have folks, and then not just us. I mean, there's Good Samaritan Clinic in Atlanta, that's not the Church Health, same idea. Clinic in Campesino in Colorado. We grew up with one of the Campesino because they do everything right. So there are lots of clinics like that around. Technically, the FQHCs, federally qualified health centers, are supposed to be for that, but they mostly get their funding from Medicaid. So like Christ Community Health Services, which people confuse that with Church Health all the time, they're different, they're much bigger, they have like 8 different offices. They see about 10% uninsured, most of their folks have 10 care. We see 85% uninsured. I mean, it's just a different niche. So.
And it was off, it was, it does. But I'm telling because it was about women. The well, no. So we do, so I'm a woman. I care about women. I think 50% of the population, I'm also reading. I'm reading Invisible Women. Y'all are all in school, you're not reading anything. When you get out of school, you should read it. It's fascinating. It's about how women are left out of our huge databases. Anyways, Church Health does an amazing job of making sure that women have access to healthcare. So that includes if you are a caregiver in the home of a child less than 6, which a lot of women are, means you're never going to qualify for health insurance. And so you can become an established patient. We have the Well, which we're one of 3 in the country that offers childcare for you while you go to your visit. So these women who are the caregivers in the home with the small children, when they want to come to the doctor, they can drop their child off at the Well, have them cared for while they go see the doctor. And that's, the fact that there's only 3 in the country, let's think about that. Are we really caring for our women if we're not providing childcare for them? And not all women have kids, and not all women, don't have childcare, but it's a huge need. And I feel like I'm really proud of the fact that we provide that. So.
start on this, you know, in whatever, in 1987, right? We started, Dr. Morris started with a little house on the corner, Peabody building, and cell phone connection. So all this didn't just matter. And it, medical director, having to be responsible for this, I can tell you, you know, it sounds all great and shiny, but yeah, it's a lot of work. So I think, unless there's a burning question, we will take a bathroom break. And then if any of you are interested, we're going to split into two and go on a tour to see the church health and all the stuff we've been talking about. Before we do that, Jonathan, is there anything you need to say about next week? Because probably once we meet here, we can come with that.
Other than, again, feel free to reach out to me if you have questions or need something. I don't think we need to say much except for one major thing, that we won't be in this room next week.
Yeah.
You've got the
We'll be up on
microphone,
the
you want
third
to describe
floor,
her?
and it's called the Idea Studio. So on the tour, at some point, you need someone, where's someone even? Yes.
Right.
So there are tour guides. So half of you follow Sam and me, and the other